are going to have the proxy. We're going to hear the proxy experiences, and these are experiences from caregivers and all those who have and who are close to those who have, living with cancer or cancer survivors. So before I go on, I will introduce to you the moderator who will take over from me now, Miss Shanice Rowe, and Miss Rowe is from Steps and Wellness. Did I get that right, Miss Rowe? Miss Rowe is from Steps Health and Wellness Center. So Miss Shanice Rowe is the moderator, so I hand over to you. Thank you.
Thank you, Valerie. Good afternoon, ladies and gentlemen, and good afternoon to those of us who are joining via our Zoom platform. Thank you so much for joining us for today's event and now for the afternoon special. We will be discussing a very important topic. Time will not allow us to go into everything that we need to discuss, but we hope to whet the appetite, get the discussion started, and we will follow through in our homes, in our different business places, and eventually reach the House of Parliament, because we need to get some policy changed, right? All right, let me introduce my esteemed panelists for this afternoon. We have a mixture of trained healthcare professionals, as well as persons who are caregivers and care partners for persons who have been diagnosed with cancer. I'll start with Dr. Owen James, who is to my immediate right. Dr. James did his tertiary education in microbiology and medicine at the Edinburgh University in Scotland. He returned to Jamaica in 1965, where he joined the Department of Microbiology, the Faculty of Medical Sciences at the UWI, and spent 22 years there as a lecturer and consultant clinical microbiologist/immunologist. He also worked as a family medicine practitioner for 13 of those years at the Shortwood Medical Center. In 1987, he joined the staff of Alcon, Jamaica, where he spent another 22 years as medical director, managing occupational health and safety. He moved on to serve as dean of the All-American Institute of Medical Sciences at its inception in 2010, and he served there for 4 years. In 2014, he was appointed part-time chief trainer for infection prevention and control at the Southern Regional Health Authority, and he retired from there in 2021. Currently, Dr. James is a member of the Jamaica Cancer Society. He has served as chairman of the CPSME. He's a founding member of associations like the General Practitioners Association, Jamaican Association for Safety Professionals, Jamaica Occupational Safety and Health Professionals, and is currently the director of the Community of Retired Persons, and chairman of the Ethics Committee of the Medical Association of Jamaica. Dr. James, please welcome him.
Thank you very much. Appreciate it.
Sorry, most importantly, Dr. James is married and has 4 children. All right. One of our panelists is online, Miss Patrice Dwyer. She is a holistic multi-potentialite, an author and community builder and a lover of life. She has been described by her clients as a transformation therapist. For over 19 years, she has accompanied and guided many persons, their families and caregivers through various stages on their journey to healing and lifestyle transformation, utilizing her skills as a complementary and alternative therapist, lymphedema therapist, and certified professional cancer coach, patient navigator, and death doula. She is passionate about promoting efficient, quality care for all, in particular those living with and impacted by cancer. And she's also an advocate for palliative care. Her insights and knowledge led her in 2020 to form Navigating Health Services Limited, a company focused on bridging the gap, creating pathways to quality health care. In 2021, she completed certification as a death doula and end-of-life care planner. She's the author of It's Your Life, Care Directive and Transition Plan, a workbook and guide providing individuals with the necessary tools to not just make informed decisions about their health, but to act on them. She is Forever Elsie's daughter and mother to Layla Harmony. So that's Miss Patrice Dwyer. She is joining us online. Back to the floor, to my immediate left is Miss Tashana Gow. Tashana Gow is a registered nurse. She earned a Bachelor of Science degree in nursing from the University of Technology. She worked at Nuttall Memorial Hospital in the dual capacity of bedside nurse and operating theater nurse for over 8 years. She attained a level 4 National Vocational Qualification of Jamaica in assessment from the VTDI and is currently an allied health instructor with Heart Trust NTA at the Garmex Academy. She has been in that position for over 7 years. Thank you, Ms. Gow, for being with us. Still on my left, we have nurse manager, Mrs. Anne-Marie Williams. Sorry, I'm just being informed that Ms. Dwyer is not online due to a technical error. Nurse manager, Mrs. Anne-Marie Sims Williams. She is a nurse manager at the Mandeville Regional Hospital, and she has been working specifically in the oncological clinic for the last 10 years, since 2013. To my right is Mr. Godfrey Taylor. Mr. Taylor is a care partner for someone who has been diagnosed and is living with cancer. To his left is Miss Joy Fairclough, another caregiver. I must say, Miss Fairclough is also a trained caregiver, but I've asked her today to give us her opinions in an informal capacity where she has had relatives and other family members and close persons who has been diagnosed with cancer. And last but not least is, in the middle here, a representative from the Practical Nurses Association of Jamaica, Mrs. Loy Robinson. She is a practical nurse and has been working at the Mandeville Regional Hospital for more than 10 years. She's a mother and a God-fearing person. She also holds a level 2 certificate in psychiatric aid. Finally, I'm Shanice Allen. I'm moderator. I'm a healthcare manager and a rehabilitation specialist. That's it for me. So you realize we have an esteemed group of people who are quite capable to challenge the questions that I'm about to throw out. And also, at the end, I'm going to ask, because almost everyone here has been touched by cancer. And when I say touched, I don't mean personally you, but someone in your family or a friend may have been diagnosed, and you would have seen them gone through the fight. Some have survived the fight, some have lost the battle, and we would want your input as well. Cancer is the second leading cause of death in Jamaica. That means it's very prevalent. It's everywhere. I want to know, and as a part of our discussion this morning, we realized that cancer strikes any part of the age continuum. So not just older people, but also children, neonates, going right up to persons who are senior citizens. Do you think that there is a difference in the sensitivity and the delivery of the diagnosis of cancer to children rather than those, that level of diagnosis and care given to the delivery to patients who are of the older group, older cohort. Let me start with Dr. James.
Thank you very much. Maybe I'm not too qualified to answer that question. My colleague to my right might be better able to, but I think in general, we have more sympathy for those at extremes of age. So for the very young and for the very old. And so we do tend to pay more attention to them, extremes of age. In between is where we may, fall short a little bit. But in terms of saying you would give a child more attention or want to raise more funds because of the child rather than an older person, that sometimes may happen because there is a tendency to say, oh, you have lived your days, let somebody who has not lived his or hers get a chance. So there may be a little bit of that in determining how much attention, whether financial, medical, or psychological, or otherwise, you give to a young child versus an adult or an older person. I think it should not be that way. Everyone should be treated pretty equally. Of course, if there is a sense of hopelessness, there is a point you reach where there is no return. But in a case like that, then you would not want to spend time and effort in wasting resources, so to speak. But on the other hand, remember, even some children, their lifespan is going to be very limited because of the type of cancer they have. Some children may be born with cancer, and they're not going to survive too long. So it's not an easy answer, but I'd like somebody else to take that one.
I'm going to throw over to Nurse Williams. In your capacity there, I'm sure you've had patients who are younger, patients who are older. Do you find that there is more sensitivity to extremes of age as opposed to persons who are in the middle group?
I don't think so, because they are managed by different teams. So the pediatric team is different from the adult oncologist.
Okay. All right. Does anybody else want to weigh in on the sensitivity within the age spectrum? All right.
Yes, I would like to. Just on. Okay. Just on the, I think just at the start, when a child, this is going in and out. When a child is in pain initially and the parents or persons around may not be sure why, I tend to find that I'm observing a time lag for the child to be carried, to be properly tested, and there seems to be a time lag right there.
Okay. Thank you very much. Mr. Taylor, oftentimes with a diagnosis, not just for cancer, the attention is given mainly to the patient. But what is true is that a cancer diagnosis is faced by the entire family. The patient may be going through the direct illness, but the family that carries them go through much of the stress and turmoil that comes with that as well. What can you tell us, being a care partner, has been your experience?
Okay. I think not necessarily in an order of priority or the chronological order in which it comes, but there are several things that you face as a care partner or the parent of, or the child of, or the spouse of, or the friend of somebody who has been diagnosed with cancer. It is true that a diagnosis of cancer changes the entire family. Things that seem so important suddenly don't seem so important anymore. But there are some things that you go through. Fear. There's also, this is not the patient now.
Yes.
Care partner. Fear, there's guilt. There's a possibility of wanting to run away. So I noticed some people gasped when they heard that the spouse of a breast cancer patient or survivor said want her out because he basically can't deal with it. maybe he should have run away rather than run her away. You also have to face your own mortality as a stage in the process. You end up having to do a reality check on yourself. But the relationship with the person and a reality check of life, value, meanings, meaning of life, and so on. There's also, hopefully you get to this stage of acceptance, where you accept the situation. Not that there's nothing you can do, but you have to come to a stage of acceptance. What might come before it, could be after, is an understanding. And then there is support. You are called upon to offer support, which sometimes doesn't go further than just being there. You don't have to have the money, but just being there. I found that sharing strengthens you. It also, I think, strengthens the patient. So that's one of the pluses of our support group. For me, for example, I have other things to lean on. So I am not left alone as some care partners are. Them one carry the burden. For me, I have other things to lean on. I have, for example, faith. I have a Christian faith. My parents are gone, and her parents are gone, but our 4 parents were deep Christians, and we are Christians too. I also have music, which is what I do now for a living, and music has always been something. While she was doing stem cell transplant, I leave her, make sure she's fallen asleep, and I go downstairs and there's a piano, and I play for an hour or two, and I soothe myself, then I can go back up and sleep. We have many good friends. I have a church family, and I have great family links, including 3 very caring and great daughters. If you have daughters, you're a lucky man. I have son-in-law, and we have granddaughters. So there is a support structure for her, as well as a support structure for me, as well as a support structure for us. And I can't stop there now, thanks.
Yes, that was very meaningful, and I must point out how much you really emphasize the support structure. And not only that, your wife needed the support structure, but you as the care partner as well benefited from the support. Just another question for you, Mr. Taylor. What was your experience dealing with the medical professionals? Were they as sympathetic to you, and were you involved as a part of care? Was care provided for you or only for your wife?
Not from the general medical, not for me, from the general medical, but I have to confess, 2 of our daughters are doctors, and the other one is a clinical psychologist. So, as well as an entertainer, let me confess. So our general experience with the medical fraternity is different from the other patients who don't have the same thing. But I found when we went for stem cell, notice I said we, like I did get stem cell transplant. When we went for stem cell transplant, what was beautiful is they ensured that before she even started the process, that we met with psychological counseling, social work, and also they sent a musician, asked us if we would take a musician. We had a musician come into the hospital room and played music and so on. So there was caring overseas that is set up by the doctors.
Right.
But I don't think it is so prevalent in
here.
Jamaica.
Right, so that's what I want to highlight, that this sort of support that you got was not within the Jamaican experience, it was overseas. I'm going to throw back to one of you to know who are working in the public health system. Are these structures in place for patients and for caregivers? This kind of support where patients and their families are recommended to see a psychologist, is art therapy, is music therapy involved as a part of their diagnosis, pre-treatment? Are you aware?
Yes, we do offer psychological support. We also let them see a dietitian that enables their nutrition, because nutrition is of utmost importance when it comes to cancer care. We also navigate the system for them in terms of offering support for diagnostic care, for their medical treatment, for chemotherapy support. We tell them where they can get support, where they can find their drugs, and so on.
Okay. Thank you, Nurse Williams. You know, I'm going to be the devil on this side here. So a lot of the times the systems, you know, I've done research and spoken to a lot of persons who have been caregivers or persons who've actually lost patients to the, lost their relatives to the fight. And while a lot of the times those structures are in place on paper, do we see them, you know, really being carried out practically with each patient? As Mr. Taylor said, you know, his experience being that, you know, his daughters and so are heavily involved in the medical fraternity is really admittedly different from what the regular person will get. So in your experience, is this being followed for every single person that comes in with a cancer diagnosis? I don't want to hear what is on paper. I want to hear what's going on down there in real life.
Yes, in real life, but like for the musical support and so on, we do not have that at this time, but we are looking into things to enhance our care for cancer patients, and so we will try to do new things to make our patients comfortable.
Okay. All right, thank you, Nurse Williams. I'm going to go over to Ms. Robinson. As a practical nurse, they are really at bedside. They are there for the guts work, right? And you will hear a lot of the utterings. And now with the event of camera phones and videos everywhere, there are a lot of videos that are going around with patients being poorly treated by patient care assistants or practical nurse when they think no one else is watching. How do you maintain a level of professionalism and make sure that, you know, you are always providing sympathy for your patient? Or have you experienced the neglect of patient from, you know, your colleagues or so?
Well, on my perspective, I also had a colleague who passed. I'm using it. I also have a colleague who passed away last year, August, with cancer, and we had a well-rounded support group in the PCA body and also from the hospital also, and her family member. Whenever she needed our support, we were there for her. So we just want to say, at times, it may be, for some patients, they don't have the support group from family, but from there in the hospital settings, we are there for them. We are there for them, even if it's even to hold their hands, because I know that the pain for a cancer patient is very horrible, and sometimes you have to put yourself in their shoe. As old-time people say, put yourself in the patient's shoe and to say or know what they're feeling. Because little pain you feel on a regular basis, it's hard. Much more patient, the pain cannot be stopped even when they get the pain meds. We're there. Sometimes we feel the sympathy for them as a relative also.
Okay, thank you, Nurse Robinson. So, you know, empathy, I gather from what you're saying, is very important. Putting yourself in the person's shoes. It might not be happening to you, but you consider yourself to be in that bed, and how would you want to be treated? All right, I'm going to turn over to Ms. Gao. As an instructor, how much time is given in the course material in training allied health patient care assistants and nurses in sensitivity training? How much time is in the course, and how much time is expected to be put in continuing medical education?
Well, as it relates to sensitivity in caring for patients, there isn't a specific set time allocated to it, but as it relates to the different diseases that a patient might go through, we do put it in the coursework that you have to practice therapeutic communication and empathy for your patients. But what we do in the classroom, as much as we can tell a student that when you go out there, you're supposed to be honest and caring, you're supposed to be listening, you're supposed to be maintaining eye contact, your body language says a lot to the patient, don't cut them off when they're speaking, make them feel like they're important. You can say all of this in the classroom, but it really, just last week, I was actually teaching therapeutic communication, and I was saying to my class, I can't only give you guidelines and tell you the things that you're supposed to do, but when you go out there, it's up to you to continue to be honest and caring and loving. So nurses and patient care assistants do get training in sensitivity, but it's up to the individual at the end of the day. They do know what they're supposed to do, they do learn the tools and the techniques, but when you step out there in the real world, you're on the ward, in the clinic, wherever you're working, I am not there to say you're not being honest enough or you're not being loving enough. It's up to the individual themselves to remember what they've learned. And not only, you can't teach somebody to love. It comes naturally. So it's also have to do with the personality of the individual. They could have learned all the tools, but they're just not a naturally loving person. And that is why I always tell persons, if this is not where your passion is, then don't come in it. Because then you can't even say you're doing it for the money anymore. Okay. You have to do it for the love. Huh?
Okay. Before I tackle that, I'm going to ask Dr. James from the medical perspective. So as physicians, if you can remember when you were a lecturer or so, how much time is actually put into sensitization training of doctors, and how much time is required in continuing medical training for practitioners?
Well,
you're a member of ethics committees.
The first part is easy. How much time is put in? The answer to that is not enough.
Okay.
Afterwards, there are several situations where we have continuing medical education sessions when the whole business of patient care and attention is stressed. But allow me to say something about time. It takes time to do everything. You know, if you turn your car ignition on now, you don't reach 60 miles an hour right away. If I cough on you now and I have the flu, you don't get the flu for 4 or 5 days. Likewise, if you come to see me as a doctor and I'm seeing a patient, you can't get seen right away. You know, two bodies cannot occupy the same space simultaneously. When I was in practice, my wife and I had to put up a sign saying, if you have come to see the doctor takes at least 10 minutes to see each patient. So if you are patient number 7, you have at least 1 hour to wait. You cannot help that. And if in the meantime, somebody else comes in who needs very urgent attention, you may need to change that and pay attention to that person. In terms of taking care of the cancer patient, some patients may think, oh, you don't spend enough time with me. I have such a dread disease, you ought to spend more time with me. That is quite true. But again, you have to face that. If you come when you're treating a patient with a heart attack or so, you can't stop because a cancer patient has come in. But when it's appropriate, you will give that patient 20 minutes, half an hour, whatever the time is, or reschedule an appointment. It's a very long answer, but the whole business of time in allocating patient care is a difficult one, and you need to handle it, you know, as best you can.
Yes.
And with sensitivity.
It's a big growth in our current situation. It's a big growth. We hear all the time persons complain about how long they have to go to the hospital and wait, and especially when you're suffering such a tiring illness as cancer can be. I recently spoke to a spouse of a person who is living with cancer, and she was waiting at the hospital for hours because the practice in the public sector is to give everybody the same appointment time, and then it's a first come, first serve policy. That is dreadful for somebody who is already unwell. And to be there waiting all day, she felt like she waited until about 3 o'clock, went in to see the doctor, who then spent 2 minutes to say, well, this is the result. It was devastating for her as the partner and also devastating for the patient. What I've realized is, though, you both, from your answers, said that, one, not enough training because we can't identify how many hours are actually put into it. And nobody said whether or not it is demanded in continuing education. So, yes, we know that there are CMEs offered in that area, but is it demanding or is it required? And is it an area that we need as healthcare professionals to step up in to better provide care for patients and their families so that their experiences can be better?
Again, you recall the Minister of Health did say it have to allocate more resources, find more doctors, more waiting rooms, whatever it is, because again, the limitation of resources will affect the time that you can give to patients. I agree with you that telling all patients to come at 9 o'clock in the morning and 100 patients come at 9 o'clock, that cannot work. That is not on. But you need to have more doctors now. More doctors now instead of the 5 or 6. You have 10 or 20, so that even if you say come at the same time, you can space it out better than that.
Thank you so very much. Thank you very much, panelists. As I said, this topic, we could spend all evening. We're just brushing on it. I don't believe we have time. I'm going to take one question if there's any, or one concern from the floor, if there's any. Sorry, yes, please. You can. The microphone is right there, sir.
In the healthcare system, so aren't we as medical professionals supposed to uphold the law of utility? So if a person has cancer and somebody doesn't have cancer, we have to prioritize the person that the utility would most benefit to save the person's life. So I don't think it's a case that cancer people is being neglected, but you have to maintain the law of utility.
Okay, just want to make sure I understand it. So you're talking about prioritization of care?
Yes, prioritization of care.
Okay.
So it's not necessarily neglect, but the law of utility as medical professionals.
Okay, okay, thank you. Thank you for your contribution. Is there anyone else? Oh, yes, sure.
That question assumes or presumes certain things that our medical professionals are gods. There are many people who are alive who doctors have sometimes mistakenly used the words like, you're still alive?
Written off, yeah.
Because they're supposed to dead. But it just so happens that the real God never planned for that person to dead. So the question of utility, while it is a rational human development, is something that we have to be careful about. For example, you could say somebody at age 40 still has productive life. A child at age 3 months, them just coming to the world, so them can go on. We don't have to spend the time with them. You see where it could lead us. I'm not saying we're not to consider it, but it could lead us. I figured the doc wanted to say something, yes. So I'll keep quiet.
So 30 seconds, Dr. James. Go ahead, 30 seconds.
Oh, 30 seconds. Just a quick one to remind us all that cancer is not something anyone would like to have. But there are varying degrees of cancer. I have friends who have cancer who are living because it's skin cancer. Took it off, no problem. I have friends who had cancer of the pancreas and they were dead in 2 months. On the other hand, I had a friend who had pancreatic cancer, lived for 6 years. So there is some variability in this. You can't say simply because you have cancer. It's a death knell. There are varying degrees, and there are also varying methods of management.
Thank you very much, Dr. James. So, yeah, very good point. I don't want you to believe that because it's cancer, it's a death sentence. So they still require utility and prioritization as well. All right, I'm going to throw over now to Valerie. Thank you so much for listening in, and we will continue this at our next sitting.
Thank you.
Thank you very much. Thanks to the panelists. Thanks, Shanice. You did a very good job, and we could be sitting here all evening, all afternoon, listening to them. Very good contribution, and thanks for the comment from the floor. So yes, we do understand the law of utility, but then there is that we have to know now how to make that ethical decision, how to keep that balance. And I want to thank the NCU students for coming here. And I want to thank you all for coming here. We're going to stop streaming at the end of this. However, the breakout session will continue, but it will not be streamed, right? So the breakout session is after this. And I just want to thank you all. And I hope that you've had the opportunity to hear from these experts, hear from these persons who you've heard lived experiences, and I hope that you can take something away from this session today. Once again, thank you.